Good afternoon, ladies and gentlemen. Welcome to the second EMS Eco Session of the year 2026 and the 109th EMS Eco Session altogether. My name is Akatukunda Precious, a nursing officer, critical care unit, Nakasero Hospital, and I'm honored to moderate today's session. Yes, thank you so much for logging in. Yes. I recently read an interesting quote that stated that half knowledge is more dangerous than ignorance. And it is at this point that I would like to take this opportunity to appreciate Ministry of Health in collaboration with Seed Global Health for their measurable impact with these innovative sessions. And I also personally believe that an empowered workforce is more committed, experiences lower burnout, and is more committed and consistent with the quality of care. Thank you. Thank you so much for logging in. Yes, I also recently, the studies with the Uganda Ministry of Works and Transport indicate that road traffic crashes and road traffic accidents contribute to an average of 10 deaths per day, every day. And I believe each one of us on call has one or two experienced road traffic accident victim. Every health worker, if you're on call, I'm sure you've experienced a road traffic accident victim. And it is for this reason, among others, that we are gathered here to explore the topic, managing a traffic accident victim. And our objectives for this session, some of our objectives for this session will be managing the key history in managing a trapped accident victim. We also have emergency assessment and on-scene care, pre-hospital care and transportation of the trapped accident victim, nursing care and emergency department management of the trapped accident victim. So I would like all of us on this call to imagine right now being the first responder of this first accident victim. What would you do? Imagine you're the one you've reached, they've called, you're the first health worker, you're the first responder of this trapped accident victim. What would you do? So it is at this point that we have an incredible panel of experts to help us explore all that. And I would love them to introduce themselves. I will start from my right. Dr. Iwaka.
Yeah, good afternoon, colleagues online. Welcome to the EMS Eco Session. I'm Chande Emmanuel, resident doing emergency medicine at Bara University of Science and Technology. Happy to be the team.
Thank you, Doctor. To my left.
Yeah, good afternoon, everyone. My name is Mildred Nakanjija, and I am a nurse working at Rubaga Hospital in the Accident and Emergency Department. Yes, and I am an instructor with the Association of Ambulance Professionals Uganda. Glad to be here.
And then to my extreme left, you're welcome.
Thank you very much. Once again, Mutambi Umar is my name. I am an EMT, but also work with the Association of Ambulance Professionals. Happy New Year to everyone.
Thank you so much. We also have experts that are on call with us. I'm going to mention one name, then you can unmute yourself and introduce yourself. I'm going to start with Dr. Tracy. Please kindly unmute yourself.
Hi, I'm Dr. Tracy. I am one of the SEED educators working with the Department of Emergency Medicine at Mbarara University.
Thank you so much, Dr. Tracy. It's an honor to have you. Dr. Omona, kindly unmute yourself. Yes. Someone called Johan. Unmute yourself.
Good afternoon, everyone. My name is Johannes Branghofer. I am ITLS instructor from Germany and specialized in vehicle extrication and responsible for the education of the fellow Ugandan colleagues from APU and the Ugandan ITLS instructors.
Thank you so much. Thank you so much for those introductions. At this point, we are going to listen to our dear participants. You can type in the chat group your expectations, and you're also allowed to unmute yourself. To raise your hand, we shall unmute, and then you are able to voice out your expectations for this session. We would love to know what is one thing you hope to learn from this session. So our dear participants, you can raise your hand or you can type in the chat. We shall be able to capture those responses. Drake Ajura, do you have any expectation for this session? There is also another person raising their hand called Peter Nason. Could you kindly unmute yourself and raise your expectation for this session?
Yeah, good afternoon, team. I'm happy to be part of this discussion today. Basically, my expectation, I think I had given it before but I just wanted to voice it now so that it really goes back. As we know, we don't have paramedicals who are always the key people in front line with regards to this response to mass casualties on our roads. So I don't know what is going to be the government will in terms of enhancing paramedical, who shall be the best people to approach these casualties at the scene, and then as we prepare for us at the hospital to wait for them.
Thank you for that expectation. We have people on call, our experts, and also our partners that are listening in and can be able to listen in and note that. Thank you. There are some expectations in the chat group. One of them says, I would love to know the first things you do as a first responder to an accident scene. Yes, I'm sure the experts are noting those and they will be able to respond to them. Feel free to type in the chat all your expectations, all your questions as we go ahead. We have an expert in the chat group that will be able to attend to all those expectations, all those questions. Thank you. Moving on forward, have you ever wondered how to prioritize this care of this trapped accident victim? Yes, I'm going to welcome Dr. Emmanuel to take us through the case presentation so that we can know the prioritization of care of this trapped accident victim. Dr. Emmanuel, you're welcome.
Thank you, Prosi, once again for the opportunity. Yeah, I am glad to present our case for the discussion. This is a patient who was trapped in a vehicle. The local EMS was activated by the police and community at 18:45 hours, and they notified the EMS about a motor vehicle accident that involved 2 lorries. And in this accident, there were a total of 35 victims. However, for today's discussion, one of the victims was this 34-year-old man who was trapped within the driver's cabin and was held in place for about 35 minutes before the first responders could arrive at the scene.
So our dear participants, there is a poll question on your screen that is appearing on your screen. We encourage all of you to attempt these poll questions because they will be able to guide our experts on what to focus on, especially with the knowledge gaps in regards to this session. So the poll question states, what are the top 3 priorities for this scene? Option A is pull the patient out by any means. No intervention can be done until then. Option 2 is flip the car over to access is easier, then secure airway, then also conduct a primary survey. Option 3 is secure the vehicle so it does not move, apply thick collar and stop external bleeding. And option 4 is perform an end-to-end assessment with one person stabilizing the neck. So I encourage our participants to attempt these options, to attempt this poll, so that our experts are guided in attempts to meet our expectations and to meet our knowledge gaps in regards to this session. Yes. And once again, the poll is what are the top 3 priorities for this scene. In case you're not able to see the poll on your Zoom, the below part, the dashboard part, you can go to polls and quizzes. In case you accidentally pressed it out, you can go to your polls and quizzes and you can tap on it and you're able to access it again to enable us to access and also experts to be able to help us where we are lacking in the knowledge gap. Our poll is going to end shortly in the next few seconds. So I would encourage us to attempt as many as possible. We have so far around 50% participation in the poll. So I encourage all of us to attempt this poll. Okay, we are going to move on forward with the case presentation. Thank you for your attention.
So this was how our team safely approached the scene. The police who reached the scene before the EMS team could reach, secured the scene by diverting traffic, by using steps and leaves. The community also supported police to control the crowd. And one of the police officers went into the vehicle to turn off the engine so that the vehicle does not catch fire. The EMTs who responded had appropriate PPEs for safety. We had EMS personnel to continue to offer on-scene care to the rest of the accident victims, and the police called the tow truck to be able to come to support to lift up the 2 lorries. And this was the incidents. This was a truck carrying market vendors. Our patient was trapped within the dashboard and had visible bleeding from the scalp with gargling sounds and had obvious signs of respiratory distress.
Thank you, Dr. Emmanuel. So our dear participants, we have our poll 2. It is now going to be depicted on your screen shortly for you to be able to attempt the question. I believe you are able to access the poll question right now. And I encourage all of us to attempt this question. So it states that patient remains trapped, what next? Our first option is give the patient analgesia, tourniquet leg, then perform field amputation, extract the patient. Option 2 is give patient analgesia, stroke fluids, tourniquet leg, then perform controlled lift of the vehicle, extract the patient. Option 3 is give the patient analgesia, stroke fluids, don't tourniquet leg, but have it ready when performing controlled lift of vehicle, extract patient. The next option is control resuscitation, first until the blood pressures are greater than 110 millimeters of mercury, and then perform controlled lift of the vehicle to extract the patient. And our final option is intubate patient first, prior to performing controlled lift of the vehicle to extract the patient. I encourage all of us in the call to attempt this poll so that our experts can be able to help us. And I also encourage us, as the case is going on, please type in the chat your questions. There is an expert to attend to all your questions as the presenter is going on. And those that you are not able to type, you can note them down after the case presentation. There could be an opportunity to be able to ask these to get clarity from the case presenter. Yeah, thank you. I encourage all of us to attempt the poll. It's right now at 42%. I encourage us to attempt because our poll is going to be closed in the next few seconds. Yeah. Thank you so much for attempting the poll. We are now going to move forward with the case presentation.
So as part of our safety, for the responding crew and for the person who's trapped, you need to stabilize the vehicle. And usually in the scene, we use whatever is available. And so in one of the images there, you can see use any piece of log around. In other places, you can use ropes so that you fasten the vehicle so that it doesn't move to ensure safety of the respondent and the crew. As we approach this patient, the top 3 priorities for this patient, we have airway threat, because our patient had visible blood in the oral cavity, and this had a risk of aspiration and caused airway obstruction. The immediate action taken was to, first of all, to stabilize the C-spine and position the airway using a jaw thrust and suction the airway. Circulation-wise, we had bleeding from the scalp, and this had a risk of causing hemorrhagic shock. This was controlled by applying direct pressure to the scalp wound.
Thank you so much, Dr. Emmanuel. We are going to our next poll 3, and it will be depicted on your screen shortly for us to be able to attempt this. I believe right now you are able to see the poll, and I encourage all of us to attend this poll so that our experts, as I had said earlier, can be able to attend to wherever we are lacking. And the poll states, when should you suspect that an entrapment of the limb that could cause crash syndrome, and start treatment prior to availability of tests? So we have 30 minutes, we have 60 minutes, we have 90 minutes, and 120 minutes. The poll once again states, when should you suspect that an entrapment of a limb that could cause a crash syndrome, and start treatment prior to availability of tests? So we have 30 minutes, 60 minutes, 90 minutes, and 120 minutes. I would encourage all of us to attend this poll. Also, in case of any clarifications, please feel free to type in the chat so that the experts on call are able to attend to your inquiries. If you've accidentally crossed out this poll, you can check on your dashboard on your Zoom. There is an option for polls and quizzes, and you are able to access this poll question once again. Yeah, otherwise, we appreciate you for logging in and attending this poll, this session. I encourage each one of us to share this link as widely as possible so that the people on the team are able to access. Let's continue with the case presentation.
So after addressing the 3 life threats the person had, now it gave us opportunity to be able to conduct a formal ABCDE assessment. So for the airway, yes, the airway was patent however, threatened because of the secretions and blood in the oral cavity. This was managed by suctioning and used jaw thrust. For breathing, patient had labored and shallow breaths, respiratory rate of 28 breaths per minute, had low SpO2 of 90% room air, reduced air entry on the right. This was corrected by administering oxygen, 15 liters through a non-rebreather mask. There was needle decompression with the right lung done. Circulation, we had active scalp bleeding with cold extremities up to the knee and the elbow, delayed cup refill time of more than 3 seconds. Pulse rate was 128, which was high, weak, and thready. Patient had low blood pressure of 86/54 millimeters of mercury. Interventions done, we had direct pressure to the wound to control the scalp bleeding. IV access was only possible on one arm with cannula of 18 gauge. And normal saline infusion was started, 500 mils. Disability-wise, yes, the person had low disease score. Eye open was 2, verbal response 2, motor response 3. Pupils, however, were equal with slight reaction. Exposure, patient was cold with multiple abrasions. Patient was covered with gloves from fellow market vendors to be able to conserve heat. Once you do ABCD assessment and interventions, you must be able to follow up response to the interventions. So this was update for the patient's management. After connecting the SpO2 oxygen, our SpO2 improved to 97% on oxygen. Blood pressure improved to 98/62. Pulse rate reduced slightly to 118. However, the Glasgow Coma scale still remains 7, and external bleeding from the scalp laceration was controlled. So what happened next to the patient? Yes, patient received, in addition to what we did in the ABC, the patient also received analgesia and continued with fluids since the patient was responsive to fluids. And the patient was removed from the entrapment by the police and the community. So the EMS crew put the patient on the ambulance bed. They repeated the primary survey and continued non-invasive monitoring using a handheld pulse oximeter. And eventually this patient was transported to the receiving site after notifying the receiving site of the estimated time of arrival and the patient's condition.
Thank you so much, Dr. Emmanuel. So dear participants, there is another poll 4 that is going to be on your screen shortly. Yes, so that you are able to attempt the question and be able to assess our knowledge. I believe the poll is already on your screen, and the poll states, life threats in acute traumatic rhabdomyolysis include all but which one? Yeah, and we have option 1 as hyperkalemia. We have option 2 as acidosis. We have option 3 as sepsis. And we have option 4 as arrhythmias. I'm going to read it again. It states, life threats in acute traumatic rhabdomyolysis include all but which one? The first option is hyperkalemia. The second option is acidosis. The third option is sepsis, and the fourth option is arrhythmias. So I encourage all of us to attempt this poll question so that we are able to give our experts a picture of where they can attend to us with our expectations. Yeah. So far we have around 40%. We encourage all of us to keep attempting the question until we are shortly done. But as of now, please, I encourage all of us to attempt the poll question. Yeah, one final time, it states that life threats in acute traumatic rhabdomyolysis include all but one. And the options are for us to choose one, which is hyperkalemia, or acidosis, or sepsis, or arrhythmias. Thank you so much for attempting the question, and we are going to continue with the case presentation.
So our second survey, we had this following relevant positives: the scalp laceration, which was controlled. We had rib tenderness on the right, and there was a cannula in situ. Crush injury to left thigh, it was a closed one, blister on the skin, and we had decreased peripheral pulse on the left compared to the right. The important negatives: no underlying skull fracture, pupils were normal, air entry there was more in the right, in the left than the right. The abdomen was soft and non-tender. The pelvis was stable. Investigations planned for the patient, they were ordered, but they are not done. This was a polytrauma patient who are ideally needed pan-CT imaging, renal function tests. We needed to do the electrolytes to rule out the hyperkalemias, chest X-ray, and we're not able to also do bedside focus, especially if fast. At handover of the patient to the emergency department, spine immobilization was maintained, pending the results of the imaging planned for the following day. Oxygen therapy was maintained, and the patient's target was 94 to 98%. The intercostal chest catheter was inserted. IV fluids were continued. 1,500 ml of normal saline during transit and also ongoing fluids, the ED. Bleeding, scalp laceration was controlled with formal surgical toilet and suture. There was immobilization of the left leg and femur with back slab. Plan to monitor vitals closely, urine output, and then to optimize the patient's comfort by titrating analgesia. Care for pressure areas planned.
Thank you, Dr. Emmanuel. We have another poll on your screen. Our poll is going to be on your screen shortly. I believe you are able to access it on your screens right now. And it states, which one is an indication for dialysis in crash syndrome? Once again, which one is an indication for dialysis in crash syndrome? We have option 1 as refractory hyperkalemia. We have a high urine output that is greater than 300 mils per hour. We have a CK greater than 100,000. And we do have a pain out of proportion to injury. So I encourage each one of us to attempt the poll. Let me be able to voice it out again. It states, which one is an indication for dialysis in crash syndrome? Our first option is refractory hyperkalemia. Our second option is high urine output that is greater than 300 mils per hour. Our third option is CK greater than 100,000. And our last option is pain out of proportion to the injury. You can attempt to choose one option of the three that you believe or think is the right option, and we shall be able to guide, experts will be able to guide through their presentations which one was the right. I encourage all of us to attempt the question. We so far have 47% of the participation, and I encourage us to all attempt the question. It will help us with our engagement with our panel of experts. And for any inquiries, please type them within the chat. There is an expert to be able to attend to all your inquiries, or you can note them down and you're able to ask Dr. Emmanuel for clarifications after. Our poll is going to end, and I call upon Dr. Emmanuel to continue with the case.
Yes, with our polytrauma patients, we continue to have management and plan to disposition care. One was to discuss with the patient and the family about the potential for loss of limb because of amputation, and also it was a high-risk injury with high risk of mortality. Then the inpatient team was activated, especially the surgical and orthopedics, for management of the leg crush. Internal medicine was activated for the possible renal complications, and the ICU was alerted because of the increasing nursing requirements for the patient, detailed fluid and electrolyte management. Specific management targets for our patients. If the patient has very high creatine kinase, we'll aim to have increased urine output 3 mL per kilogram per hour. For the renal impairment, you need to flush out the myoglobin from the tissue damage. Strict fluid balance to ensure that the patient is getting adequate hydration, and monitor renal functions and electrolytes frequently, which in our case, we're not able to even get the fast lab reports. Especially in the electrolytes, we need to monitor the potassium for the hyperkalemia. Injured leg, yes, put a back slab and elevate to enhance drainage, and monitor for increasing pain, swelling, and immune pulses, which might be a pointer to compartment syndrome. Then for the severe traumatic brain injury, neurocritical care bundle was activated for the patient. Thank you.
Thank you so much, Dr. Emmanuel. We really appreciate your time and effort that you took in preparing this case. It's been well structured and it's been very engaging. We do appreciate your time and effort in preparing this case. Thank you. This question goes to our participants. Have you encountered a case like this before or similar to it? You can type in chat so that we're able to know, oh, these cases are actually happening. They're actually common. You can just let us know in the chat. Thank you. And next on our, at this point, participants, in case you have any questions or clarifications in regards to the case that has been presented to us, kindly unmute or raise your hand, and we are able to pick you up, and you can get all the clarifications you need from Dr. Emmanuel or the whole panel of experts that is with us today. In case you have any inquiries, please raise your hand, or you can type it in the chat and I'll be able to read it out for the case presenter. Yes. Ochongoa Jobik, please kindly unmute yourself and raise your question. Thank you.
Yes, thank you so much. I'm Ochongoa Jobik. I would like to know whether when the person was taken to the facility, whether was transfused, because I'm seeing there was a risk of bleeding, which would have reduced our BP. Secondly, about our disability, whether the disability was also mounted, and that's now regarding to our random blood sugar. Thank you.
Thank you, Mr. Jobik, for your question. Do we have any other question? Because this has been noted, he's going to attend to it. But in case we have any other question, please kindly raise your hand And as you're preparing your questions, I can, Mr. Emmanuel Wasanja, please kindly unmute and ask your question.
Yes, thank you so much for the brilliant presentation. This is a small inquiry. I would like to know what was the indication for the needle decompression, because all we saw was reduced air entry, I think, to the right. Not sure about that. So that was the only finding. So I would like to get more light about that. Thank you.
Thank you, Mr. Emmanuel, for that submission. I welcome Dr. Emmanuel to attempt those two submissions. Thank you.
Yeah, thank you, colleagues, for the questions. Let me start with the Jobbik. You had two issues. One was whether the RBS was done. Yes. At the scene, the RBS was not done because the ambulance did not have a glucometer. And the patient, that was an oversight, the patient received 2 units of packed cells at the ED. My namesake, Emma, for the question about the needle decompression. Yes, there was reduced air entry, but the team was convinced because of the mechanism of injury the patient had. We also know that a potential tension pneumothorax, if not managed earlier, a pneumothorax, if not managed earlier, can worsen the patient outcome. And we already saw the patient already had hemodynamic instability, which usually can be one of the pointers to tension pneumothorax. So that was why the team at site made that decision. It's usually not a clear-cut decision to make, but it's very dangerous not to attempt if the person has tension pneumothorax than attempt and you get a negative result. Thank you.
Thank you, Dr. Emmanuel. There is one question in the chat. The experts are going to be able to attend to some of these questions as we go ahead with our case presentations. Especially, I've been seeing one of the questions, how to secure airway while on scene. We have the pre-hospital team that is going to able to guide us through that. So some of the questions are going to be attended to with the panel of experts as we go ahead. It is at this point that I invite the pre-hospital team to take us through the case management that has been presented. Thank you. Mr. Umaru, you're welcome.
Thank you very much, our moderator. But again, thank you so much, Emmanuel, for that wonderful presentation. I mean, when you silent and listen into the scenario, trapped patient, silent question could be like, okay, trapped patient in what? We've seen it in I know the car that has turned. And what does this mean? That in your plan, in your thinking, start imagining, how did it land on the ground? Is it upside down? Is it on the side? Silently ask your questions. What exactly happened? Why did it even get to this extent? So as a pre-hospital provider, I mean, it is important for us to sit back when probably before even the call, because we know these are the cases that we have on a daily basis. And it would be very important for us to also sit back and appreciate that they are going to call us. And among the cases we're expecting probably is trauma RTA, where we have a number of vehicles in this. So the pre-call, an idea of the situation would be, as an ambulance responder, as a person who is on the ambulance, silent, I need to ask myself, okay, this one has overturned. What do I need to do? I should be able to go ahead and tell myself, do I have the right equipment? Fine, maybe I have the equipment. Is the personnel trained? Do you have the expertise in accessing this patient in a similar scenario? But above all, we all know that within the country, the first responder is the Uganda police, where we know that the key responsibility that I have as first responders is to help us manage in this scenario. And that is why it is important for you and me to maintain that good communication and the collaborations with the fire brigade, because one, they are the ones who have the right equipment, and we would love to see ourselves not missing out anything. Okay. So, communication which confirms trapped patient. This is a trauma patient. Please, please, please take it upon you as an individual that your tools to do the job are available with you. Lucky enough, today we are one of the blessed ones that we could look at the key tools that we might need in this particular incident. And I also want to view to the common discussion around that, these are very bulky equipments and everything. With us, some of the tools you need to actually carry on your ambulance, and that should help us to plan and be able to think that my job is going to be well done and should be able to take up. As soon as you get there, think about sizing up the scene. Take note that sizing up would involve a number of things for you, but above all, don't forget to call for help. You're not an expert in putting out fire. You're not an expert in probably, I would say, clearing out the electric wires that would be around. So the scene in your plan should give you that wider thinking. What exactly is there? But call for backup, call for help. Let's learn to call. And then I like it where our presenter emphasized stabilization. It is the role of you, the EMT, if you want to access this patient, not to forget that you must stabilize your vehicle. And then from there, start asking, what do I have in my suitcase? I've gone to the supermarket. I want to access my patient. Why is the patient trapped? Which compartment? And then I plan my access to the patient. As soon as you have accessed the patient, never forget to stabilize. You need to stabilize your patient, and we should be able to look at that. Extrication has taken place. Plan your transfer. Plan your transfer. People would really need to understand where we go next. Okay. Something for us to bite. With me, I am saying that the few items you have here are good enough for you to run on your ambulance. Talk about a crowbar, different sizes. Okay. Talk about the hand cutter. Think of the elegant tool. How about my hammer? We have some ropes around. We'll be passing there. The cribbings, all what we would call the chokes. This saves us a lot, and at the end of the day, you're going to find yourself in that particular incident. This is something that one can have on your ambulance. This is called an elegant tool. You need it. Put it under the ambulance where you have your patient seat. Secure it very well. The magic is here. Your car is threatening to have fire. Your magic is on this end. Poke two holes. One where you're going to aim the nozzle of the fire extinguisher. When it comes to cutting out your windscreen because you want to access the patient, you have the edge. So I have 1, 2, 3 in one. And just looking at this, it is enough for us to have an ambulance. So why are we making it so complicated that I cannot have this? It is possible. We can have it, okay? I have talked about the cutter. Sometimes people don't want to agree You want to cut the big tools you have there, push it under or behind the passenger seat. It will take a very safe place in there. And when time comes, you'll find yourself very friendly when it comes to using it. Okay? So I want to filter the common discussions where people say it is not easy for us to access, it is very difficult. The level of hammer. I have my hammer. What do I want to hit out? Rather than you picking that axe, yes, very good, community is supporting, but let's act professional. As an EMT, you need something that is going to support you out. You want to bend out a fold. Let's have the edge clipped very well. It will help you to unfold. And at the end of the day, we'll have this. We are saying, think about your tools. You want to increase your visibility. Okay? You'll have it to the different levels you want. Safety, safety, safety. So when we talk about increasing your task and knowing what to do, I mean, in a distance, in the night at all times, we're going to be seen. Yes, we'll be safe. I know I want to break the glass. I am talking about the tools. Look at this. Many of us have these pocket knives, but we know what to use them for. At that time when you want to cut, even if you have forgotten, you will slide in here your belt. And at the end of the day, we are going to see ourselves have it out. Maybe I found it a bit challenging at that time, and I want to access something that looks like a knife. I have it out. If I want to break the glass, I have here the hammer. Many of our ambulances have some of these tools. So you have safe access. You are inside there. I want to open the bonnet just to bend it. Really? Why are we really making it so complicated? No, the tools, the equipment. Ladies and gentlemen, this is with us. You need to have the right equipment as a professional. You need to ensure that you're going to access your patient safely. So as soon as you've had your patient with us, fine, I want to advance it. I have my cutter. It is electronic. This I charge from my house. I will come and I have it be positioned very well. It is on. Are you sure this is so bulk? Maybe someone there is saying it has a lot of weight and everything. No, it doesn't have that weight. And then when I say it's time to work, it will work. You might see, fix my blade. I am going to cut out that particular component that is challenging me. So ladies and gentlemen, when we talk about how safe we can access, these are some of the few things that we could include when preparing for the tools. And that is where I come in to say that, yes, important above all, let's not forget that as professionals, it is very good for us to appreciate and then see basic equipment as called them. Back to our case. Pre-hospital at 18:45 hours on that date, we're seeing ourselves responding. And as we go in to respond, we confirm a vehicle that has been actually overturned. I want to imagine this scenario. Yes, the rolly was overloaded, maybe due to the terrain, but something I want us try to remember whenever they tell you someone is trapped, and the common one. If you look at the image that we have, you should be able to tell me the signpost says 20 kilometers per hour. And then it also indicates a sharp bend. And in the next minute, we are seeing ourselves the car has overturned. So when it overturns, what is it that you want? And this would be my approach. As soon as I size up, you'll agree with me. One thing that walks to my mind is the ITLS algorithm. It clearly gives me a direct flow on how to manage my scene. Where they put emphasis on myself, they put emphasis on my patient, addressing the life-threatening condition. So when I size up, I want to give tasks to my team members. I know I have called up the backup. I have the right equipment, the right personnel. Everyone is in. I have tasked the different individuals on what to do. I will conduct a 360. So with a 360, I want to look under, I want to look in the sides, I want to look over the car. I will go to the rear part, confirming that everyone is on board. Internally, we have already now turned off the car engine because we have assured our safety. The airbags have not been deployed. I have safe access inside my vehicle. I go an extra mile to stabilize. After ensuring that I am smart, I have run very fast because this is very important. When we talk about PPE, ladies and gentlemen, do not compromise your personal protective equipment when we are managing trapped patients. Please, please, please. There's a lot of glasses flying around. You need your goggles. You need the heavy jackets on you. Why? You could be dealing with spills. You could be dealing with... Talk about everything. This is one area I wouldn't really want to see probably trying to compromise when it comes to this. And put in mind your mechanism of injury. I am aware you have done the call of help. Never forget. Maybe community did the screaming. Let them continue until you're sure you have the right personnel coming in to give you a hand. Mobilize the community. Yes, they are coming in. Give them tasks. Have the plan. Who is going to handle what? Once you have that, never forget to know that every incident needs a leader. Dear pre-hospital, we need to work with the members around. For you to minimize the rest, you need to have them be controlled. Take them through, let each and every person know what to do. At the end of the day, we need to execute the task. My plan, vehicle stabilization, we have the car jack. Remember to raise it. Let's try to remember that you can also use these, what we'll call the chokes, the small stones where you have, and then be sure that the car is stabilized. Never ever have yourself exposed to that before. That's one of the good chokes. Please ensure that the tires are well stabilized. As soon as you're done with that, let's go ahead and access the patient. I showed you my elegant. I now need to break the glass. I have told you you could use anything. The whole essence is how do I get it to her? I am using my elegant to cut out the windscreen, and I'll have it be moved so that I can have clear access to my patient. After that, stabilize the patient. It is important for us. Remember, the entire interior is now safe. One of the members confirmed to you, no deployed airbag. We also know that the car is on handbrake, the engine is turned off. My colleague has taken the back seat to support. I am going to run my initial assessment very fast to rule out anything that is going to kill the patient. In this incident, you remember very well, that we had one of the key things very clear, where we looked at someone with a skull fracture. It is bleeding. The question is it catastrophic? No, it shouldn't really divert me off. And then I immediately plan how to have my patient. After my initial assessment, I have confirmed it is in, and then I want to make sure that the rapid trauma survey is done. When I do my rapid trauma survey, I have confirmed that now this is a load and go. I don't need to actually go into drills, start thinking of the other because of the general mechanism of injury. He's in, head to toe. I am now going to run it as soon as I have my patient out, load him there, and now I have the answers to the silent questions of the status of the airway. Is my patient still breathing? Circulation, I don't have any catastrophic bleeding. I want to do my other details when I have the patient taken on board. However, it is smart for us to plan our referrals. If you really know from your rapid trauma survey, it's detailed and has given you all this, are you prepared with the equipment? I have my C-collar in position. I have probably binded in a scenario where I have a threatened binder. And then I am planning to have my patient transported on a spine board, have the right personnel. And now here we plan, not forgetting that as I conduct my assessment, you and me should remember that during my primary survey, it is only when I have hazards at the scene that I will have to interrupt my assessment. If I discover the massive hemorrhage, I am going to intervene. Or probably if I confirm that the airway is being obstructed, I will have to interrupt my primary survey, and then if someone arrests. To those who wanted to know, yes, I've conducted my primary survey, I have limited time. Yes, those are the exceptions that would come in. As usual, the algorithm is very clear. It reminds us that, remember, when you're conducting your initial assessment, specifically for such patients, what's the overall impression? Don't forget stabilizing. Is my patient in response? Did I see any catastrophic bleeding? Am I in position to address all the life-threatening conditions? And the moment I confirm, yes, I go off. Team has already come. I have the right equipment. I am good to go to start performing. Common mistakes as pre-hospital, we underestimate the scene in terms of hazards. It is important for us to note in this particular threat, spills were key things that we should never forget. Fire due to maybe hot engine, anything could really rhyme around there. And then you and me must remember that the fire extinguisher in your ambulance, they need to be as close as where you are. Confirming that this is a load and go, it's a decision made from your assessment. The patient has a number of benefits that we should not ignore. That timely access to care. Remember, he's also going to benefit care in transit, but also it will help you to have the reduced stress. As you all know, when you're in a crowd of people, everyone is giving you what they have in mind, but that does not stop us from taking documentation. It is important to record, because at the end of the day, it should be that you are handing over a patient, and the recommended handover would you prefer is the SBAR. Please use SBAR. It will answer all our silent questions. And in this particular case, you all remember that approximately 35 minutes before we arrived to the scene. So a lot has been done. Don't come down and pour. Let it be reported. People need to remember that this has been taken note of. And as soon as you get to the facility, I am telling you, tell us what the background was. We confirm the patient because the people who came faster than us, this patient needs oxygen. They didn't forget that. And was given oxygen on the NRM, which was very great. But then also during ambulance, the key things we don't forget that we need to manage, we did direct pressure. BPs have been taken. In this particular incident, we are even seeing ourselves trying to ensure that the patient is well covered. The cold extremities with support of the community, and even our CAP refill could communicate a number of things. So the moment I hand over my patient, I make simple recommendations, as already highlighted. What is the patient going to benefit from? Confirming from the search, we realize that the jugular veins have been extended visibly, and confirming that the needle decompression was great. Having our patient elevated while transportation. Remember, I had that injury, but also don't forget to ask for the orthopedic surgeon to support. I just want to say thank you so much. It is important for me and you to remember that when you train, you'll be smart to prepare, have the right equipment, work will always be very easy, and we shall always hand over patients that are very smart. Thank you once again, moderator.
Thank you so much, Mr. Ntambi Umar, for that insightful contribution and expertise and those real world examples that we got to envision. I remember asking you, are you an engineer? Yeah, so thank you so much for the real life examples that you were able to make these equipments known to us and making them as easy as possible. I think some of the key points I've gotten from this discussion is we need to call for help as the paramedic. Do not be a know-it-all. Then get the right equipment as a professional. Let's not compromise with access. The community has brought me a hoe, the community has got me an axe. Let's get the right equipment because it can fit in our ambulance. And then also do not compromise on our personal protective gear. There could be fire, there could be broken glass. So we are not supposed to compromise with our personal protective equipment. And get a team leader so that we are not disorganized at the scene. This one is doing this, we get a team leader for this scene and also stabilize. Then we can go ahead to stabilize the patient. And then also you emphasized on the ISBA handover format. So this has been a great presentation. Thank you so much for those insightful contributions. Yes, I could take a question from the participants. So kindly write your question in the chat, or in case you have any clarifications from Mr. Ntambi Umar, please raise your hand and your question is going to be captured. Kindly raise your hand for the participants in case you do have a question in regards to Mr. Umar's presentation. And if there are no questions, this means that it's been a great and it's been well exhausted presentation. So thank you. Next on our agenda is the nursing care of the trapped accident victim. I personally believe that nursing is the heartbeat of healthcare. And right now we are going to listen in to the nursing experts. Thank you. Ms. Mildred, you're welcome.
Yes, thank you so much, Precious. Yes, like she said, everyone in the room here is laughing because she mentioned that nursing is the heartbeat of the hospital care and everywhere. Yes. So just go in and I have some introduction here for everyone to think about it. So road traffic accidents, they are the major causes of trauma, and they do often result into life-threatening injuries. And those patients that we do receive, they really present with a complex clinical challenge because of multiple injuries. Therefore, your initial management as a nurse for these trapped patients, because sometimes if you're lucky and they are brought by a trained team, maybe you have less work to do. But if they're just picked by community members, this requires you a systematic, prioritized approach. And you will have to focus on rapid assessment, stabilization, and preventing further injuries. So nursing care plays critical role in ensuring, one, you want to make sure that your patient's airway is patent. You want to support their breathing if indicated, though in a trapped patient, it's clear they will need. You want to maintain their circulation, then control pain, as pain might stop you from doing your proper assessment, then prevent further complications, and also do what Precious said, we are the heartbeat, so we provide psychological support. So I will not have to repeat what most of my colleagues have mentioned. I'll straight go into my nursing care plans. However, I want to let you know that if you receive these patients, absolutely you're not going to start with your nursing care plan. My approach would be, I'll follow the ITLS algorithm, definitely. So I will initially start with my initial assessments. I want to know my level of consciousness, my patient's level of consciousness. I want to rule out if there is any massive bleeding. Then I'll check into the air with that algorithm very nicely. I will do it. Then also go to the other side of the mechanism of injury, and I perform my rapid trauma survey before I intervene, before I draw a nursing care plan. Because remember, nursing care plan is individualized. It's not something that you will do for every patient. And how to come out with it nicely, it's because of your proper assessment. And your assessment, I emphasize, it's do your initial assessment, go through your ABCs very fast, then head to toe in trauma patients. So from our assessments, I came up with, these are some of the nursing care plans we can draw as nurses. According to, I will let some to the case that was presented and then draw more light on the patients you can receive. So mostly, because of in this patient, we had bleeding, and because of our mechanism of injury, this patient is being trapped in a car. We are more suspicious that we could be having internal bleeding that we aren't visibly seeing. So my first nursing care plan would go on as from our subjective data, because our patient's level of consciousness could be reduced. So we are thinking of taking the history. They are trapped in a car. Then on our objective data, we have active bleeding. So as we keep assessing in our C, we have in relation to the case we have a delayed capillary fill time of 3 seconds, greater than 3 seconds. We have a pulse rate that is 128, but weak and thready. So meaning our patient is already having signs of shock. So I'll draw a nursing care, a diagnosis of decreased cardiac output related to hemorrhage, secondary to trauma, and it will be evidenced by poor tissue perfusion. That's in regards to our case, what I've just mentioned. Now, my goal, my desired goal should be bleeding control in less than 5 minutes, possibly. So within 2 to 5 minutes, I want to control this bleeding. Then I also want to ensure that all my tissues are well perfused. The patient is well perfused. And how will I do this? So these are the interventions that I'll do and the rationale as why I do everything. So I will apply direct pressure. If I have now, like on the scalp, I'll apply direct pressure. Also put a pressure bandage because I'll not remain there doing it. My hands have to be free. Then in my rapid trauma survey, from the mechanism of injury, it's directing me to be suspicious of pelvic injury. So I will insert a pelvic binder. And why am I doing this? I want to prevent more blood loss. Is it important? You ask yourself as a nurse, is it important for me to control blood loss? Yes. Why? Because you want to have all your tissues well perfused. So please, bleeding control is very key, and you call for help. You can't do it alone, right? So after bleeding control, since my other desired outcome is to have my tissues well perfused, I will definitely go on and insert 2 large bore cannulas. Tell nurses, let's go away from using yellows in adults. So please insert a large 2 bore cannula, and your rationale is it will enable you to do your fluid resuscitation or blood, because your patient will benefit more from what they have lost. And to ensure that I have adequate tissue perfusion, I'll administer IV fluids. But keeping in mind, if my patient needs blood, chest for blood. And here, preferably, I would go on and I use Linger's lactate. My goal is I want to restore the circulating volume. Remember, we have lost, and we want to have all tissues perfused. So why do I even go in for Linger's lactate? Because, you must be having a reason for whatever you choose as a nurse. So Linger's lactate, preferably its composition is close to that of blood. It is it has a good composition. So I would go for it. And even if I'm to give it in large volumes, I would want to avoid some other complications. So I would go on for Linger's lactate, and we are not giving it anyhow because I have to give 4 liters or anything. Always keep in mind, every time you give, you reassess. So then don't forget to monitor your your vitals. Mostly look at your cup refill time, look at the pulse, the blood pressure, and most importantly, keep this patient warm. Why? The rationale is, as you're monitoring, you could receive a patient who comes in just the compensatory state of shock. Most of us recognize shock when the BPs have gone down. So as a nurse, it is very important for you to tell when they are still in this, when their cup refill is delayed, they have a weak pulse, but their BPs probably they are still stable. You as a nurse, as you keep monitoring all this, it helps you detect that we are decompensating. All our shock is becoming worse. And then why do we have to keep them warm? It's not just a matter of say, okay, I have to cover this patient. So if your patient, his clothing are soaked in blood, please remove them, provide warmth. So why is it important? We want to avoid hypothermia. Why avoiding hypothermia? Hypothermia will affect your coagulopathy. Your patient is bleeding, so you want them to stop bleeding. So if you keep them cold, because we know that those enzymes that help us in clotting, they don't work in cold. So the moment your patient is very cold, it's affecting them. So I encourage you to keep your patient warm. And then our outcome in our evaluation, so we want to evaluate, and in this patient, after that time, bleeding was controlled, and we had improved tissue perfusion in regards to our case also. So that is one nursing diagnosis I would formulate. Then the other would be, now in the airway, in regards to our case, and clearly from the mechanism of injury, this patient is trapped. So in the objective data, obviously we had a blood in the oral cavity, also gargling sounds, which are indicative of fluids in the airway. So we have effective airway clearance. We are relating it to facial trauma, and the evidence is that visible blood in the mouth. What is your goal? Your goal is to have a patent airway, always. So what will you do? One, definitely, you are now in the ED, so you will carry out suctioning, and your rationale is to remove those secretions. And I want to draw more light on this as nurses, as you're carrying out suctioning, please, you should know what to use and always know that we only suck out what we are seeing. So please don't go far to, suck out what you aren't seeing. So we only suck out what we see. Then in the airway here, it being that our patient is in it was RTA, we want to maintain the cervical spine immobilization. We shall do inline spine immobilization. We want to prevent small injuries on the spine cord, right? And since our goal is to have a patent airway, if your patient's level of consciousness are reduced now, in our case, you will not be there to always do a jaw thrust. Your hands have to be free, and you want to have a patent airway. So we go on and insert airway adjuncts if you have them. So these are preferably in trauma patients. You want to go with an oropharyngeal airway if they can tolerate it. All right? And your goal is to have your airway patent. That's why you use it. Yeah, so that is one of the other nursing care plan we can draw as nurses. Then the other, because from our case, obviously, there is pain. And you want to control this pain because you're, in this case scenario we are relating to the mechanism of injury, of course, because patient can't score the pain. Then, and in the objective data, definitely could be, the patient could be moaning, you're seeing visible wounds, fractures and everything. So we can come up with a diagnosis of acute pain, and we are relating it to tissue injury, possible fractures. Evidence is that continuous moaning, and then the obvious injuries that you're seeing. And what is your desired goal? You want to have pain controlled, at least within 30 minutes. That's a good time scale to have your patients control, your pain controlled. Then our interventions and the rationale. You should be having a rationale for everything you're doing. So one, before you come up with any painkiller that is being prescribed, you cannot advise. So you want to start with pain assessment. Like you want to assess the severity of the pain. This will guide you on the treatment. It's very, very key. Because you will give someone is having a pain of 8 and you're coming with a very weak painkiller. Then you will go on to administer the prescribed analgesia. Your rationale will be relieving pain. Then if you having fractures, you want to go on and carry out immobilization. Why? It's preventing your pain from worsening and as well further injuries. Also, you do the goal, our heartbeats, of reassuring these patients. You want to reassure them that if their level of consciousness is, if they are able to understand whatever you're telling them, because in this way, you're reducing their anxiety that could be related to pain, one, and they are becoming more calm. They are able to tell you more of how they are feeling that would help you in your management. You would have missed out something in your assessment, but the moment your patient is more calm, they are able to tell you everything. Then it's also very important for us to, if an investigation is being requested, they have told you to take this patient for an X-ray or scan or something, this is a trauma patient, please prioritize it. Why? It's going to help in quick decision-making. And then it guides on the better management plan. You could be linked with a patient in your ED who needs to enter theater immediately. And it's you, the nurse, having this patient. So it's also part of your nursing care plan to take those patients for investigations that are being requested. Cool. So the other nursing care plan we can draw in such patients who are trapped could be having a problem with our breathing. Remember, someone is trapped, You don't know what went to their chest. Now in these patients, in our objective data, we had labored and shallow breathing regarding to our case, then the respiratory rates and everything, and delayed respiratory rates, that is 28 breaths per minute, as well as reduced air entry. So we are having infective breathing partners, and we are letting them to chest trauma, evidenced by that increased respiratory rate, shallow breath. What is our goal? To have effective breathing partners and adequate oxygenation within shortest time possible. So in here, you want to administer oxygen to improve on oxygenation levels. And then also, you want to keep on monitoring your patients. You want to monitor their respiratory rate. You want to monitor their chest movements. Why? You want to detect respiratory compromise. If they are not improving, are they improving on what you have given them? So that's why it is vital for you to monitor. And also in the case scenario we had a pneumothorax. So it's very vital for you to assist into preparation for this needle decompression. Then lastly, that we can come up with, which we know we sometimes miss, is the wound care. It is also very key as for us nurses to take care of these wounds, these injuries that patients have sustained. So our diagnosis, it can be impaired skin integrity. We are relating it to tissue damage. Evidence, of course, obvious, open wounds that you're seeing. Your goal is one to promote a proper wound healing. Then what will you do in your interventions? The first thing is you want to assess the wound characteristic. Before you go into dress and everything, you want to know the size, you want to know the depth. It is very important, as it will provide you the baseline for monitoring that wound. And then you, as you're doing it, absolutely, yes, you're under an adrenaline rush. Maybe the patient was bleeding, but right now they aren't. You've controlled it. So you want to dress this wound, think of the aseptic techniques. Why you want the rationale is for you to prevent infection. Then use appropriate dressing. It's very key. As well as it's vital to perform your hand hygiene. This looks small, but it's very key. So the rationale of you performing the hand hygiene before and after the procedure is you want to reduce on the microbial transmission. Then in your evaluation, you will keep reassessing your patients. So there are very, very many nursing diagnoses we can come up with trapped patients. But one thing I want to emphasize is you always do your proper assessment. It's from your assessment that you will get your nursing diagnoses, and it is very important for you to keep on reassessing your patient. Don't say my evaluation will be after an hour. That's when you reassess. Thank you.
Thank you so much, Ms. Mildred, for that elaborate presentation and your unique perspective on caring for a trapped accident victim. Some of the key points I've gotten from this is reassess your patient, reassess our patient. Also have a rationale for everything you're doing, and also prioritize investigations for quick decision making. And mainly, our assessment will guide our nursing care plan. So let's do our proper nursing assessment. Thank you so much for that unique perspective. I believe our audience has gotten some actionable points that will take us forward. Thank you so much. I'm going to continue with Dr. Tracy, then we shall note questions for Mildred, and we shall ask them for after the session, towards the end of the session. Dr. Tracy, I would like to welcome you for your presentation. Thank you.
Okay, are you able to see my screen?
We are not yet able to see your screen, Dr. Tracy.
It's saying that my screen share is paused.
Your screen is on, but it's dark.
Apologies.
Yes, perfect. We are able to see your screen now, Dr. Tracy.
Thank you. Okay, so apologies for that delay. So as mentioned, my name's Tracy. I'm one of the emergency physicians supporting Mbarara, but in a previous life, I was a pre-hospital physician working in Australia for a couple of different services, including the Royal Flying Doctors Service, and I was director of the retrieval service for a period of time. And as part of our role as pre-hospital clinicians, we not only provide the pre-hospital transfers, but we work with paramedics and fire and police to attend primary hospital scenes and provide the medical care in conjunction with them doing the extraction. So it's this perspective that I'm going to provide you today, with an emphasis on crush injury. So I do not have the skills to talk to you about how to cut open a car, but the whole point is that we are there to support the patient and advocate for the patient's needs during that extraction injury event. And this is different from if you're having to do both the extraction and the patient care that we talked about earlier with that primary responder going and doing both at the scene. Something that I just wanted to emphasize that I don't think we've actually spoken about to date is that you've got to remember that the safest extrication is the one that the patient is able to do themselves. So gone are the days when we actually force patients into an extraction device to be able to get them out of vehicle. We know that they are far better placed to be able to protect their own anatomy than if they are able to do so and have the sensorium intact to achieve this, than to us to force them into an extraction device. So I just wanted to emphasize that it's an adjunct to not forget the simple things are actually quite useful in these situations as well. So if you can make a path for them to get out, that's probably the best way to go. There's a reason why we emphasize PPE in the pre-hospital environment, and I'm just going to quickly re-emphasize this for people that don't routinely work in the pre-hospital environment that are going out there. You actually need to be able to return to your family and your job the next day. So you need to protect yourself to be able to continue with this work. And it's generally, you want fire retardant, ideally, but thick clothing so that you don't kneel on broken glass. And similarly with gloves, if you're working in that tough environment. And the other point that was made before that I think is worth emphasizing as well is these are often quite chaotic team environments with multidisciplinary crew that are involved. So really that leader is very important that Mr. Umura talked about before. There should be only one person in charge, and all because you're the medic on the scene doesn't mean that you are the person that's in charge. So often that in charge role will be deferred to the fire in that hot zone of a scene of accident. But as I mentioned, you are a patient advocate. So your communication skills are really important. So you need to be able to make clear what your plan is with the rescue team. And you also have a role in keeping that patient calm and protected during the extraction as well. So having very clear communication with the extrication or rescue team and using simple language like go, stop, to communicate when things are safe to proceed or not can be a very nice way of ensuring everyone is on the same page. As the medical person on the scene, you can see here there's two parts to the extrication. There's the extrication process that we've already spoken about in some detail, and then there's the extrication, there's the patient assessment. And so as part of your conversation when you're making a plan with the rescue team is that you need to actually decide how quickly does this patient need to be extricated. Is this a patient that can be stabilized, that has sort of some resuscitation that can occur in the position that they're in? And so you have time to perform a more detailed extraction? Or is this a patient that is crashing and needs to get out now? And that changes the approach and the detail that is done for the rescue team. So that's the first sort of point of assessment that you need to make clear. Because this talks specifically about crush injury, it's important to appreciate that the removal of that compressive force, so whatever is holding that person in place, is one of the most critical phases of extrication. And again, the method and the timing need to be closely coordinated between both the rescue technicians and the medical personnel to ensure that that happens in a coordinated manner and no one's sort of taken by surprise by deterioration that might occur. You've planned for it. So why is the sudden release of this compression so worrisome? I've seen some of the comments in the chat, so I just want to really emphasize some of those points that have been brought up in discussion. So prolonged entrapment is defined as anything sort of greater than 60 minutes, and that's when you start to be concerned about crush syndrome, which is perhaps a generic term for what we more correctly term traumatic rhabdomyolysis. Okay, so skeletal muscle is pretty resistant to ischemia and can last a couple of hours before it starts to break down. But when in the context of an injury, you actually have direct damage to the skeletal muscle. And the damage is generally considered proportional to the degree of compressive forces, and that's a relative degree because long life of someone who is elderly can also be end up with a crush type injury. The amount of muscle mass and the duration of compression injury as well. So the things that we worry about are hypovolemia, acute kidney injury, and hyperkalemia. So these are the sort of major life threats that can occur. Obviously, when you talk about degree of muscle injury, the lower limbs are generally have larger muscle mass, and so prolonged entrapment by the lower limb has a higher risk of crush injury or crush syndrome. And you can see here that the injury will often end up with that overlying blistering of the skin, the discoloration, and changes in distal pulses. And down in that bottom right-hand corner, you can see that coke-coloured or tea-coloured urine, which is one of the things that we're so concerned about. So the different types of mechanisms by which this traumatic rhabdomyolysis occur is a combination of these factors. You've got the myoglobin release from the skeletal muscle, which can cause direct toxic injury to the renal tubules, but can also, it's a very large protein, so it can also form casts within renal tubules and cause that acute kidney injury. Obviously, when you've got breakdown of cells, you've got release of intracellular potassium, so hyperkalemia is a concern. The cells themselves are sort of being bathed in a toxic environment. They have direct injury and their cell membrane becomes a lot more permeable. So the cells begin to swell and the metabolic acidosis and lactic acid that builds up as a result of the prolonged ischemia is also going to be problematic. Because when you suddenly decompress that limb, then you get this ischemia reperfusion injury. So you get a rush of blood into the limb. You get movement from the extra to intracellular compartment of those leaky cells. So your first life threat is really going to be a hypovolemic shock, and hypotension is one of the ones that you're going to be seeing in the first instance. The sudden release of acids will cause a vasodilatation, and the potassium has a potential to cause a ventricular arrhythmia as well. So VF would be the thing that you're most concerned about, and obviously arrest that goes along with that. So in the longer term, your acute kidney injury can continue and progress to acute renal failure. You can develop systemic symptomatology of DIC, acute respiratory distress syndrome, sepsis down the track, and this becomes a multi-organ failure. And of course, you also have the potential for compartment syndrome in the crushed limb as well. So this is the concern of releasing a crushed limb. So unfortunately, there's not a lot of high level evidence base established to manage this, particularly in the pre-hospital setting. A lot of the data is retrospective data from big data banks that have come from the disaster medicine environment, particularly around earthquakes, etc. So dealing with that one-on-one patient in the pre-hospital environment hasn't really got a lot of sort of high quality evidence, and it tends to be sort of, individual expertise, which we know is the lowest form of evidence that's out there. But there are some general recommendations that come as a result of this. One of the questions that comes up time and time again is, can I prevent toxin release with a tourniquet? So if I release the crushing injury, does having a tourniquet on that limb prevent them from having that deterioration? And I'm just going to quickly divert into a clinical skill here, just so that we are actually all aware of what we're talking about. So this is not just a piece of material tied around the leg. It's we call it a combat application tourniquet, or a windlass tourniquet that actually basically causes an ischemia of the lower limb, okay? So if I was just to quickly go through, this is just a couple of minute video.
Let's say my buddy has an arm wound about right here.
Why is that done? Apologies.
You want the cat to sit 2 to 3 inches above the injury. For most people, that's about 3 finger widths. So you want the cat to go about here. Ideally, the cat should be applied directly to bare skin. You can apply the cat temporarily over clothing, making sure there are no solid objects in the way. Loosen the cat and then slide it over the injured arm. When it's in the right spot, pull the band tight. Then secure it back around itself, but not over the rod clips. The cat is tight enough when you're unable to fit 3 fingers underneath it. If it's too loose, pull the band open, tighten it, refasten it, and recheck its tightness. Now twist the rod. Your goal is to get the cat tight enough to stop the bleeding. Lock the rod into place and check for bleeding and a distal pulse. If there's still bleeding or a distal pulse, you can tighten the cat with the rod, or even consider applying a second cat right above the first. Once the bleeding has stopped and you can no longer feel a distal pulse, the cat is properly tightened. Now you can route the band between the clips and over the rod. Secure the band with the time strap and record the time of application on the time strap.
So
let's say my buddy
if you have if you don't have a combat application tourniquet, which I imagine a lot of places won't, then you can actually do this with what you can achieve at the roadside as well. This is just an example of one that we sort of came up with the other day.
Any piece of cloth
folding it into at least a 1 inch to 2 inch thick width. You don't want something so narrow that it's going to cause a pressure injury at the site of the actual tourniquet application. Say the wound is here, we want to get the clothing out of the way. We want to have the tourniquet first applied just proximal to the wound to salvage as much of the leg as possible. I'm going to put that in place. Then going to use a stick that is firm enough not to be easily broken and wrap your cloth ends in opposite directions around the stick, and then you're going to twist to tighten the tourniquet until it's firm enough that you lock off the blood supply. Then once it's in place, once you're happy with the firmness, you're going to stop it from unwinding by then securing that stick in place there.
So I think that's probably the types of equipment that you are going to have at most roadsides. So it is available to use and should be used in preference to just tying or using a narrow, I often see Foley catheters or something like that being used, because this is the only way that you're going to be sure to achieve ischemia of that ling, which is ultimately what you're looking for. So having shown you that and having shown you the tourniquet, do we actually use it in a crush injury? So remembering the mechanism of injury that I just spoke to you about. The answer is that there is really insufficient evidence to recommend the routine use of the tourniquet prior to release of the crushing force, but it is recommended that you should have it in place and ready to tighten should that patient deteriorate on release. So this is part of why it needs to be a well-coordinated process when you're releasing that compressive force, okay? And most pre-hospital services and international disaster response recommendations are against sort of the routine application of a tourniquet to a crushed extremity unless there's active catastrophic hemorrhage. And we know on our initial assessment, it goes C, ABC in trauma. So that catastrophic hemorrhage is what you're looking for, not specifically the crush injury. Okay. So what can we do then? The most important thing when you're approaching a scene and you're worried about this is that you get that IV access in. You start the patient on high flow oxygen, if it's safe to do so in the space, and you start them on a monitor, because really that monitor is going to be probably the most available non-invasive clue that we're going to realistically have access to at the roadside in this current environment. A well-resourced pre-hospital crew might have a iStat with them, which can provide a point of care potassium at the roadside, but that's yet to become available and readily dispensed in the current setting. So when we talk about hyperkalemia, when we're talking about getting the monitoring on, what we're monitoring for is evidence of hyperkalemia. So often these patients are quite stable prior to the release of the injury. So the things that the changes that we're looking for on ECG are going to be a prolongation of the PR interval, peaking of the T wave, loss of the P wave, and widening of all of the intervals until you finally get a sine wave leading into a VF arrest. And that roughly correlates with the changes as you go up through the levels of potassium. It's not exact, but you certainly should be looking for those at least on your ECG.
So if you do see evidence of hyperkalemia on the ECG, you want to manage for that. You can anticipate and have these drugs drawn up ready to administer. And in the first instance, you'd ideally like to preload with a calcium solution to stabilize the membrane. And that's going to buy you a little bit of time and hopefully make the heart a little less reactive to an influx of potassium. Other than that, we can use shifters, which shift the potassium from extra to intracellular. And that's going to be your insulin dextrose and your salbutamol. But again, very temporizing. And if you're really quite concerned, then probably in a trauma patient, the main additional medication that you might use is going to be sodium bicarbonate. Furosemide you're not going to use in a trauma patient, and you're not going to want to have anything orally or PR, or perhaps you could give it PR. And hemodialysis is clearly not going to be available until you're in hospital. So you have those medications ready to go. You pre-treat with your calcium, and you can give a fluid load as well. If your compressive force is still in situ after you've started that management, you do that controlled and coordinated release, considering the tourniquet, having it in place, having that IV fluid bolus, and anticipating shock, hyperkalemia, and dysrhythmia, and being ready to respond to that. If your compressive force isn't in situ, then you're in a much better situation, and you're going to keep going with IV fluids, analgesia, elevate and splint the ling, and then the ultimate fluid is going to be diesel and getting that patient to hospital. Okay. Once in hospital, after you've done a very nice detailed assessment as outlined by our nursing colleagues, you want to manage the kidneys, and this is going to be with early aggressive fluid resuscitation. So hypervolemia and fluid shifts are going to be one of the early causes of death in these patients. Typically, a kidney-related injury occurs with a higher level of CK, and the cutoff tends to be around 20 times the upper limit of normal. And our IV fluids are actually going to be a lot. So we're aiming for a urine output of 300 mils an hour. And so that's about a 1 to 3 milligrams per kilogram per hour output within that first 24 hours, because we really want to keep that flow going through the kidneys and stopping the myoglobin from causing further damage to the tubules. The evidence around the addition of mannitol and the addition of bicarb to improve the or decrease the impact on the kidneys is pretty controversial, and there's not a great set of evidence for head-to-head comparison of these medications. You can give mannitol if the patient is starting to become fluid overloaded and you want to increase that osmotic diuresis. And then obviously the sodium bicarb can alkalinize the urine and help improve outflow that way. You're going to avoid the mannitol if they're anuric though, because that's not going to help suddenly make the kidneys make urine. And then I saw in the chat there was some conversation around, saline versus Ringer's lactate. What do we do? The big concern about using large doses of normal saline in these patients is they already have a kidney injury, and you can cause a further kidney injury with that large volume of hyperchloremia, causing a hyperchloremic metabolic acidosis. So if the only fluid you have is normal saline, then you want to alternate that with dextrose to try and make, it'll still be an isotonic solution, but to try and decrease that chloride load on the kidneys. So if you have an isotonic solution to use, then yes, you should go with that. And the targets that you're aiming for is to continue until the urine's cleared of myoglobin. So with that high fluid bolus that you're going to be giving people, you obviously need to do a really nice fluid management chart and monitor how much is going in, monitor how much is coming out, so that you can anticipate if this patient is becoming fluid overloaded and all the consequences that go with that. So this is where nursing care is super important to that detail in the management. Remember that we don't detect myoglobin on dipstick, but we have a proxy for it because myoglobin will light up as hemoglobin on the dipstick. So that's one way that we can sort of monitor it for it across time. And if you do a microscopy and there's no red cells, but the dipstick tests positive for hemoglobin, then that's definitely going to be myoglobin. That's if the patient's kidneys do well. However, if patients have an acute kidney injury in the context of crush syndrome, the vast majority of them are going to end up on hemodialysis. So you need to consult nephrology early, because their fluid management and their hemodynamic status means that they may actually need high frequency, low dose hemodialysis to support their kidneys through this insult. So that's sort of the main management of kidneys. And then there's the management of the limb itself. So we already talked about not tourniqueting unless we have to, and the tourniquet is just going to prolong the actual crush injury itself. So we want to restore circulation as soon as possible to that limb. And we're going to splint it in its anatomical position because of ongoing issues with, sort of contractures, etc., down the track. Now, there's no evidence that routine fasciotomy improves outcome in these patients. So all because you have a crush syndrome doesn't mean that you also have a compartment syndrome. You should only do a fasciotomy if there's evidence of compartment syndrome as well. And you want to be monitoring for that and doing that early so that you can prevent as many complications as possible. It may be that there's still quite a bit of necrosis in that leg and it's not salvageable at that point, in which case then down the track you're going to be considering amputation. If a fasciotomy is done, this dramatically increases the nursing requirements as well for wound care, for management of or monitoring for distal perfusion, etc. And any time that you make a cut in an ischemic limb, then the increased risk of bleeding, coagulopathy, sepsis, and mortality goes up. So whether that's because of the cut or whether it's because the actual injury underlying it that's made you necessitate the cut is a chicken and egg situation. So, but what we can do is good attention to wound care in that setting to try and prevent the sepsis complications particularly. Just a quick reminder, compartment syndrome. The other therapies that are available but are not necessarily available currently in this setting, icing therapy, equivocal sort of outcomes there, and then hyperbaric oxygen therapy, also pretty equivocal. And I think the closest hyperbaric chamber I saw was in Dar es Salaam, so probably not something that we're going to have access to here. Compartment syndrome. So the things that you're looking for are the 6 Ps: pain, pallor, paralysis, paresthesia, poikilothermia. So that just means, yes, it's cold, but it actually sort of tends to adopt the temperature of the surrounding environment. So it doesn't necessarily have to be ice cold, but relatively cold compared to the other limbs. And then pulselessness will be a late sign. And this can manifest anywhere from 2 to 48 hours post an injury. So as I said, the complications are numerous. So it's really important to do that regular monitoring, monitor the RFTs, monitor the electrolytes and careful fluid balance, because we're worried about both hypo and hypervolemia, hyperkalemia, hypocalcemia, the lactic acidosis, the renal failure, the compartment syndrome, and then the long-term functional loss, contractures, and potential amputation of that limb. And these patients have a high mortality. So in an earthquake situation where the resources are overwhelmed, the mortality can be as high as 50%. In a patient that is closely monitored, they may still have a mortality of 20% with the, the kidney-related injury from the myoglobin. So in summary, crush injury can lead to crush syndrome, which has significant comorbidities. Quantifying the risk of crush syndrome can be challenging, but is based on the patient's exposure, the degree of muscle involvement, and the length of time that that's been in place. So you have to anticipate it and prepare for clinical deterioration, but that should not delay extraction. Routine applications of tourniquet is currently not recommended. Early fluid resuscitation absolutely is. So pre-extraction, during extraction, after extraction, and then throughout their whole kidney injury, fluid is key. Dialysis is likely to be needed in AKI, refractory hyperkalemia, and if the patient's having difficulty managing the large volumes of fluid. And routine fasciotomy is not recommended unless there's evidence of compartment syndrome. So that brings me to the end of the component to talk about crush injury. If we have time, I've got a section on pelvic binder application, but I think we're probably going to run out of time just now, so I'll stop sharing here. Thank you.
Thank you, Dr. Tracy, for that elaborate presentation. It's always a pleasure to have your expertise. It's always a pleasure. We have so much to learn from you. I think some of the key points I've gotten from your presentation is regular monitoring, guidance on application of the tourniquet, the management of hyperkalemia, where we have the membrane stabilization, the shifters, the excretors, treatment of crush syndrome, we have to manage the kidneys and the limbs. And also you emphasized on early resuscitation and always regular monitor our patients. So thank you so much for that elaborate presentation. I will take one question, and as you're raising your hand, I would like to invite Dr. Omona to emphasize on some of the questions that have been asked in the chat, so that those that you would wish to elaborate more verbally, we request that you kindly unmute yourself and emphasize on those. And those that have questions for Dr. Tracy, I encourage us to raise your hands, and those will also be captured as Dr. Omona is giving his presentation. Dr. Omona, you're welcome.
Thank you, everyone, and it's nice to have this presentation. Thank you all our presenters. The presentations have been really good. Most of the concern on the chat have been about safety of the responders, which I think it was dealt with very well in the presentation, so I'm not going to repeat on that. The other was about IV fluid, ringers versus a normal saline. In that chart, we are saying the earlier the patient get the fluid, the better. Don't deny because there are some people who are saying deep in the villages, they may not have this, they may not have this, but we say give the patient the fluid you have as early as possible. Then there was a concern about the priorities. I think the first priorities were also handled in the presentations, so I'm not going to repeat also on that. And now there's one person who talked about on-scene amputation. Was asking whether we should amputate on the scene or we should wait and then amputate at the emergency department or for definite care. Now, in Uganda, our
Dr. Omona, I think we've lost you. Dr. Omona, are you able to hear us? Let me welcome Mr. Johans to give us some insights from today's presentation. Would love to hear from you as Dr. Omona gets some stable internet. Mr. Johans, please, you're welcome. Mr. Johans, you can kindly unmute yourself and talk to us. Thank you. So I'm going to invite my panel of experts to give their cutting shots in a sentence or two as they emphasize on our takeaway points. And I'm going to start again with my right, Dr. Emmanuel.
Yes, thank you, moderator, for the session. This trauma is one of our leading morbidities we do see in the ED, and also hospital. After MNSH, we do see trauma. And so what we do first to the patient, the golden hour, determines the outcome of this patient. So we must learn, and act timely. Thank you.
Thank you so much, Dr. Emmanuel. Ms. Mildred.
Right, so thank you so much. Mine still goes to my fellow nurses. I just want to emphasize that always you need to do assessment as nurses. It is very key. And then a nursing care plan should always be individualized. Please reassess and evaluate your care.
Thank you so much, Ms. Mildred. Mr. Umar.
Thank you very much. Mine, I'll still emphasize safety. And in this, I want us to take more precaution when it comes to PPE as pre-hospital providers, but not forgetting that being that trauma is one of the leading challenges, I just want to implore everyone to undertake the ITLS course. It will sort a number of issues. Thank you so much.
Thank you so much. My panel of experts here, I would love to hear from Dr. Tracy, your cutting shots. Could you kindly unmute yourself and let us know some of your cutting shots or our main takeaway points from this session?
So if it's to do with crush injury, it's anticipating a deterioration post extraction and having everything ready to respond to that. And then really detailed attention to fluid and electrolytes in the hospital phase so that you can know when complications arise early.
Thank you so much, Dr. Tracy. At this point, we are going to post our post-test so that we are able to go through the questions that we answered and we assess after the session, how are we doing now? Yeah, so the post-test is going to be on your screens shortly. But as we're answering the post-test, if there is anyone who has a question, this is still your opportunity to unmute yourself and ask that question once again. And the chat is still open for all those people who are not able to unmute themselves. You can post your question in the chat. The post test, I believe, is right now on your screen. I'm going to quickly go through the questions, then we can move on. So the first question is, what are the top 3 priorities for this scene? And the first option was pull the patient out by any means. No intervention can be done until the next option is flip the car over to access. So access is easier, then secure airway and conduct primary survey. The other option is secure the vehicle so it doesn't move, apply C-collar and stop external bleeding. The other option is perform an A to E assessment with one person stabilizing the neck. Question 2, kindly, in case you're able to see the post test, you can scroll through. There are more questions down. The next question is, patient remains trapped. What next? So the first option is give patient analgesia, tourniquet leg, then perform field amputation to extract the patient. Then the next option is give patient analgesia, stroke fluids, tourniquet leg, then perform lift of the vehicle to extract the patient. The next option is give the patient analgesia, stroke fluids, do not tourniquet the leg, but let it rest until when performing controlled lift of the vehicle to extract patient. Then also continue resuscitation first until the systolic BPs are greater than 110 millimeters of mercury, then perform lift of the vehicle to extract the patient. The next question 3 is when should you suspect that an entrapment of the limb that can cause crash syndrome and start treatment prior to availability of the tests? I think this Dr. Tracy had emphasized on it, but our options are 30 minutes, 60 minutes, 90 minutes, and 120 minutes. Our fourth question is life threats in acute traumatic rhabdomyolysis include all but one, but which one? We have hyperkalemia, we have acidosis, we have sepsis, we have arrhythmias. Then our fifth and last question is which one is an indication for dialysis in crash syndrome? We have refractory hyperkalemia, we have high urine output greater than 300 mils per hour, we have CK greater than 100,000, and pain out of proportion to the injury. So these have been our post-test questions. Thank you so much for attempting the questions. You can continue attempting these questions, and as we go on, we kindly request all of you to switch on your cameras. We'd like to see the people we've been talking to throughout the session. So you could switch on your cameras and we take a group picture. Thank you all for logging in. I can see Chirabo Catherine. Thank you for logging in. Thank you for logging. Beatrice, thank you. Ida, thank you for logging in. Mzee Isaac, thank you for logging in. Can say hi to us. Esther Ayawale, thank you for logging in. Tony Sempereza, thank you for logging in. Waswa Rodrick, thank you for logging in. Thank you so much for logging in today's. Yes, thank you so much for logging in. JP is back. Thank you.